Hello everyone, this is the third video on acid-base balance and imbalance, and in this video we are going to study about metabolic disorders of acid-base balance, that is metabolic acidosis and metabolic alkalosis. Specific learning objectives of this session are: at the end of this session, students should be able to describe metabolic disorders related to acid-base balance, that is metabolic acidosis and alkalosis, with respect to their causes, compensatory mechanisms, clinical features, biochemical changes, laboratory diagnosis, and management in brief. This is Henderson-Hasselbalch equation for bicarbonate buffer, and this equation is like a foundation for understanding all acid-base disorders in the body. I suggest all of you to make a visual imprint of this equation so that you can understand the causes, compensatory mechanism, and laboratory diagnosis and everything about acid-base disorders. So this equation states pH is equal to 6.1, which is the pKa of bicarbonate buffer plus log of bicarbonate to carbonic acid. So we should know the three values of three parameters like pH, bicarbonate, and carbonic acid, but this carbonic acid cannot be directly measured. So we get the value of carbonic acid by multiplying this value of partial pressure of carbon dioxide by 0.03, and the ratio of bicarbonate to carbonic acid is maintained at 20 at physiological pH. And any change in the bicarbonate level which is present in the numerator, and this is a base component of this equation, and the change in this bicarbonate level will lead to metabolic disorders, and this bicarbonate level is regulated by kidney. Likewise, the carbonic acid which is present in the denominator is acid component. It is regulated by lungs, and any change in the carbonic acid level, that is in the partial pressure of carbon dioxide, it leads to respiratory disorders in the body. So for understanding the acid-base disorders, we need values of three parameters. The first one is pH, second is bicarbonate, and third is partial pressure of carbon dioxide. So the normal range of pH is 7.35 to 7.45. If it is less than 7.35, it is called as acidosis. If it is more than 7.45, it is called as alkalosis. Now second parameter, bicarbonate. The normal range is 22 to 26 milliequivalent per liter. This parameter is present in the numerator and it is a base component, and decrease in bicarbonate is associated with decrease in pH. So if bicarbonate level is decreased than 22 milliequivalents per liter, it results in metabolic acidosis, and if it is more than 26 milliequivalent per liter, it results in metabolic alkalosis. The third component is partial pressure of carbon dioxide, which is our acid component. And if it is more than 45 millimeters of mercury, the acidity will increase. So it will lead to respiratory acidosis. And if it is decreased, and if it is less than 35 millimeters of mercury, the condition is termed as respiratory alkalosis. Let's begin with the first metabolic disorder, that is metabolic acidosis, and it is due to primary bicarbonate deficit. I shall explain the disorder with the help of Henderson-Hasselbalch equation so that you should be able to correlate the changes in equation with the acid-base disorders very well. So from this equation you can see that there is decrease in bicarbonate level, and it is associated with the change in pH in the same direction, and the ratio of bicarbonate to carbonic acid becomes less than 20 here. What are the causes of metabolic acidosis? We know that metabolic acidosis is characterized by increase in hydrogen ion concentration, decrease in pH, and decrease in bicarbonate concentration. So the increase in acidity, that is increase in hydrogen ion concentration. So there can be increase in hydrogen ion concentration, or there can be decrease in bicarbonate ion concentration. And the increase in hydrogen ion concentration can be due to increase in acid production either, or decrease in excretion of acid. So the first cause is increased production of acid, and this occurs in the conditions like diabetic ketoacidosis. In diabetic ketoacidosis, there is overproduction of the ketone bodies which are acidic in nature, like acetoacetate, beta hydroxybutyrate. In lactic acidosis, there is increased production of lactic acid. In prolonged starvation also, there are production of ketone bodies. So increase acids in the body will result in increased utilization of bicarbonate for neutralization of hydrogen ions. So it will ultimately lead to metabolic acidosis. Or there can be retention of acid by the kidney, means kidney is not able to excrete the acid, excrete the hydrogen ions, and this occurs in the condition of chronic renal failure, that is nephritis. Now, which are the conditions which directly leads to decreased bicarbonate ion concentration? So it can be due to loss of bicarbonate by gastrointestinal tract or kidney, and it can occur in the conditions of diarrhea or renal tubular acidosis. In clinical situations, the causes of metabolic acidosis can be again divided into two types, like increased or high anion gap metabolic acidosis and normal anion gap metabolic acidosis. So to understand that, we should first understand what is anion gap. Anion gap is a difference between measured cations and measured anions. So sodium and potassium represents the measured cations in the plasma, and chloride and bicarbonate represents measured anions in the plasma. Actually, to maintain the electron neutrality in the plasma, both cations and anion level should be equal. Sodium and potassium represents 95% of cations, and chloride and bicarbonate represents 80% of cations. So the gap or the difference between these cations and anions, it is anion gap. So if we put the normal values, we get the result as 12 milliequivalent per liter. So normal anion gap is 8 to 16 milliequivalent per liter. Actually, it is not a physiological reality. It is just represents the unmeasured anions in the plasma, which are like albumin, phosphate, sulfate, and other organic anions. So let's see what happens in increased and normal anion gap acidosis. This picture represents the normal condition in plasma, where potassium, sodium levels are normal, bicarbonate and chloride levels are normal, and anion gap is also normal. So in metabolic acidosis, what happens? There is decrease in bicarbonate ion concentration, and this to maintain normal anion gap, this decrease in bicarbonate ion concentration should be accompanied with increased chloride concentration. But when this doesn't happen, when decreased bicarbonate is not associated with increased chloride, this anion gap will increase, and this is called as increased anion gap acidosis. What happens in normal anion gap acidosis? So in metabolic acidosis, there is decreased bicarbonate ion concentration. So to maintain the electroneutrality and to maintain the anion gap, the chloride concentration is increased. So when decreased bicarbonate is associated with increased chloride ion concentration, the anion gap remains normal, and the condition is called normal anion gap acidosis. So now let's see how causes of metabolic acidosis are classified. So increased anion gap acidosis is seen in conditions like methanol toxicity, renal failure, iron isoniazide, that is INH toxicity, diabetic ketoacidosis, ethyl glycol poisoning, alcohol toxicity, lactic acidosis, salicylate poisoning, starvation. Normal anion gap acidosis is seen in diarrhea, ureterostomy, small bowel fistula, renal tubular acidosis, carbonic anhydrase inhibitors, adrenal insufficiency, and pancreatic fistula. You can get multiple choice questions on this topic, and you might get confused here, that you should always remember renal failure. In renal failure, there is increased anion gap acidosis is seen, and in renal tubular acidosis, there is normal anion gap acidosis is present. So let's talk about the compensatory mechanisms in metabolic acidosis. As we know that the primary defect in metabolic acidosis is decrease in bicarbonate level, and because of that, bicarbonate to carbonic acid ratio becomes less than 20. So body tries to bring back this ratio primarily by decreasing the carbonic acid level from the blood, and that is by decreasing partial pressure of carbon dioxide. So respiratory compensation is the primary compensatory mechanism. The respiratory centers are very sensitive to changes in pH and hydrogen ions, so they get activated. There is increased rate and depth of respiration. It leads to hyperventilation. More carbon dioxide is exhaled from the lungs, and it will lead to decrease in partial pressure of carbon dioxide. But this mechanism is not a permanent solution, because hyperventilation cannot be prolonged. So then after some days, the renal compensation sets in, now body tries to bring back this ratio of bicarbonate to carbonic acid normal by increasing this bicarbonate level in the body and by increasing the excretion, means to decrease the hydrogen ion concentration in the body. We have studied this renal compensatory mechanism in our previous video in details. So which are those renal compensatory mechanism? The first one is reabsorption of bicarbonate. Means all the bicarbonate which is filtered is recovered by the blood, means by the body. Second, there is secretion of hydrogen ions and which is accompanied with generation of new bicarbonate. And third, there is production of ammonia from glutamine, and there is excretion of hydrogen ions in the form of ammonium ions. So by virtue of renal compensation, body tries to increase this bicarbonate ion concentration and decrease hydrogen ion concentration and bring back this ratio to normal and pH to also its normal range. Which are the biochemical changes in various stages of compensation? If we know the values of pH, bicarbonate and partial pressure of carbon dioxide, we can easily diagnose the various stages of compensation, and we can also diagnose the any acid-base disorder. So we know that in metabolic acidosis, pH is reduced, bicarbonate concentration is reduced, partial pressure of carbon dioxide is normal, and the ratio of bicarbonate to carbonic acid is less than 20. Now when you can say it is a partially compensated state? When pH, bicarbonate and partial pressure of carbon dioxide all are in reduced, means all are decreased, and the ratio is less than 20. So you can say that this is partially compensated state because pH is still decreased, ratio is still less than normal. And when you can call it as a fully compensated state? When bicarbonate and PCO2 they are decreased but pH is brought back to normal and ratio also becomes normal. So this condition is a fully compensated state. What is the maximum limit of compensation? As we know that in metabolic acidosis there is primary bicarbonate deficit. So primary change is in decrease in partial pressure of carbon dioxide. But there is certain limit up to what the lungs can hyperventilate. So the maximum limit of compensation is 15 millimeters of mercury for partial pressure of carbon dioxide. And for every 1.25 milliequivalent per liter decrease in bicarbonate, the partial pressure of carbon dioxide is decreased by 1 millimeters of mercury. Metabolic acidosis is associated with hyperkalemia. It is increased concentration of potassium in blood. Normally, concentration of potassium ion in intracellular compartment is more than extracellular compartment. But in metabolic acidosis, there is increased hydrogen ion concentration. So there will be entry of hydrogen ion from blood into a cell in exchange of potassium ion. So more potassium ion now leave the cells and comes into blood, so that it results in hyperkalemia. Diabetic ketoacidosis is also an important cause of metabolic acidosis, and it occurs due to insulin deficiency. The sodium potassium pump is blocked in this condition because of insulin deficiency, and the potassium ions from blood cannot enter the cell and they remain in the circulation, and it also results in hyperkalemia. Coming to the management of metabolic acidosis, the important aspect in the management is identification of the cause and treatment of the underlying cause. IV fluid should be given generously, and in severe condition bicarbonate therapy is considered, and it depends upon the base deficit and weight of a patient, but it should be given with caution because the bicarbonate therapy can result into sudden hypokalemia. So this was about metabolic acidosis. Now we will study about metabolic alkalosis. Metabolic alkalosis is due to primary bicarbonate excess. So here there is increase in bicarbonate ion concentration, increase in pH, and the ratio of bicarbonate to carbonic acid is more than 20. Causes of metabolic alkalosis. Metabolic alkalosis is characterized by decrease in hydrogen ion concentration, increased pH, and increased bicarbonate concentration. So when there is loss of gastric juice with hydrogen ions from the body in case of prolonged vomiting and duodenal obstruction. So when there is therapeutic ingestion of alkali or antacid in the treatment of peptic ulcers. When there is overdose of diuretic drugs. All diuretics cause increased flow of fluid along the tubules, and this effect leads to increased reabsorption of sodium, which is coupled with hydrogen ion secretion and increase in bicarbonate reabsorption. And because of that, it leads to decreased hydrogen ion concentration and increase in bicarbonate ion concentration. When there is excess of corticoids, like in case of Cushing syndrome, in case of Cone syndrome, there is increased mineralocorticoid activity. So in that condition, the aldosterone, which is important mineralocorticoid, it increases the activity of sodium hydrogen exchange protein in the kidney, and this causes the retention of sodium ions and excretion of hydrogen ions. Hypokalemia is also associated with this metabolic alkalosis. We will see in the next slide how hypokalemia is associated with metabolic alkalosis. Hypokalemia is decrease in potassium ion concentration in blood. In case of alkalosis, when there is decreased hydrogen ion concentration, more hydrogen ions moves from intracellular compartment to extracellular compartment in exchange of potassium ions. So more potassium ions move from blood to cell. So there is more concentration of potassium ions inside the cell, and this leads to hypokalemia. The clinical features of metabolic alkalosis are associated with the cause, but when it is associated with hypokalemia, it causes fatigue, numbness, muscle cramps, and muscle weakness. Compensatory mechanisms in metabolic alkalosis. In metabolic alkalosis, there is increase in bicarbonate, increase in pH, and the ratio of bicarbonate to carbonic acid is more than 20. So by compensation, body tries to increase this ratio and bring back this ratio to normal, that is by increasing partial pressure of carbon dioxide. So first is respiratory compensation by hypoventilation, that is by decreasing the rate and depth of ventilation. So more carbon dioxide will be retained inside the body, and it will lead to increased partial pressure of carbon dioxide. But this, as we know, this is not a permanent solution. So then renal compensation sets in, and the primary aim is to decrease the bicarbonate concentration from the body. So it is done by decreasing reabsorption of bicarbonate, decrease in secretion of hydrogen ions and generation of new bicarbonate, and third is by decrease in production of ammonia and excretion of hydrogen as ammonium ions. The biochemical changes seen in metabolic alkalosis are pH is increased, bicarbonate level is increased, PCO2 is normal and the ratio is more than 20. In partially compensated state, all the parameters pH, bicarbonate and PCO2 are increased and the ratio is more than 20. In the fully compensated state, both pH and ratio becomes normal and bicarbonate and PCO2 is still increased. The maximum limit of compensation for PCO2 is 50 millimeters of mercury, and for every 1 milliequivalent per liter increase in bicarbonate, there is 0.6 millimeters of mercury increase in partial pressure of carbon dioxide. Management of metabolic alkalosis includes treatment of the underlying cause, electrolytes to replace the loss, and IV chlorides containing solution should be given. So this was about the metabolic alkalosis. The next topic is respiratory disorders of acid-base balance, that is respiratory acidosis and respiratory alkalosis. Thank you so much.